Good evening, good afternoon, and good morning to all of you across the world. I am Dr. Mohit Bhandari, bariatric, metabolic, robotic surgeon, and a bariatric endoscopist who is welcoming all of you to this endeavor called as the Virtual Bariatric University, started by me and my mentor, my teacher, Professor Fobi. And we welcome you to the episode 18th of this Virtual Bariatric University, which brings to you one of the most special feature, the endoscopic bariatric interventions. I would no more call it as the new kid on the block because it is already an established, well-published entity, something which should find place in the algorithm of all bariatric programs across the world. Let me introduce our stellar group of faculty to you today. We have with us Professor Barham Dayyeh from USA. Abu is a very close friend of mine, and he works in Rochester. In the department, he is the professor of medicine, director of advanced endoscopy, and director of both bariatric and metabolic endoscopy at the Mayo Clinic in Minneapolis. He's also the chief of bariatric and metabolic endoscopy committee of the IFSO and is a co-chair of bariatric committee of American Foregut Society. He has multiple patents on his name, and he's the founder of a venture-funded startup company focusing on endoscopic treatment of diabetes and metabolic diseases. With more than 200 peer-reviewed articles published, Dayyeh is one of the major stalwarts in this field. Abu, a warm welcome to you. My relationship with Abu goes a long way, and I'm so proud to have a friend with so many accomplishments. We have next with us Professor Alqathani. Professor Alqathani is a consultant in minimally invasive and obesity surgery at King Saud University, and he is the CEO and medical director of the New Medical Center. He's also the director of the King Saud University Obesity Chair and is one of the most prominent Saudi bariatric surgeon. Professor Alqathani was a founder member of Pan-Arab Society of Metabolic and Bariatric Surgery and was the president of this society in 2018. He's also a founder member of IFSO Middle East chapter, the MENAC chapter. And he's the chair of the membership committee of Saudi Arab Society of Bariatric and Metabolic Surgery. Professor Alqathani is known because he has published the largest series of endoscopic sleeve gastroplasties, somebody we all look forward to learn, understand, and improve ourselves. Professor Alqathani, a warm welcome to you to this endeavor, Virtual Bariatric University. I have with me Professor Gontrand Lopez-Nava from Spain. Gontrand, again, is a close friend, but Gontrand is the director of bariatric endoscopy at HM Shinaro University in Madrid in Spain. He is one of the most famous obesity endoscopists in Europe, and he's an expert and key opinion leader there for bariatric endoscopy. His expertise includes intragastric balloons, endoscopic gastroplasty, small bowel therapies for obesity, and has practiced and tested 14 different types of intragastric balloons. He has pioneered the automated endoscopic suturing device, which is still in development. He has authored extensively in bariatric endoscopy, and he's an invited speaker to most of our IFSO meetings. I presume that Gontrand probably is one of the only gastroenterologists practicing just bariatric endoscopy in Europe. And I think Gontrand deserves this accolade of being one of the most famous and sought for bariatric endoscopists probably across the world. Gontrand, I'm so proud to have a friend like you, and I look forward to work with you with many other projects, including teaching and training. Welcome to this show.
Thank you.
We have Professor Mousa Khoursheed from Kuwait. He's another great teacher, friend, and mentor. He's a professor of surgery in Kuwait University at Taiba Hospital and is a board vice chair and the head of the Department of Surgery and MIS division. Professor Khoursheed started bariatric endoscopy in that part of the world and is an active member in SAGES, IFSO, and ASMBS, somebody we see in all IFSO meetings, involved actively in the field of bariatric endoscopy. He's also the director of Annual Kuwait Postgraduate Assembly of Surgery, and he's doing courses since 2002, an editorial board member for surgical laparoscopy and endoscopy, and also a reviewer at obesity surgery run by IFSO. Welcome, Professor Mousa, and it's such an honor to have you, to see you after a long time. I hope you're doing good.
Thank you very much.
Last but not the least, my teacher, my mentor, I should say that this is because of this person here, because of why I'm here sitting in front of you, doing this course, because he taught me and he made me what I am today, Professor Manoel Galvao Neto from Brazil. Let me tell you, he's not only a teacher to me, but thousands and thousands of bariatric surgeons across the world. And that's why I am so honored to introduce my teacher. I do this job in most of the meetings when I introduce Manoel, but this time when he's at the virtual bariatric university, it's an extreme privilege. So Manoel is scientific director at Endo-barrier Institute in Sao Paulo, Brazil, an affiliate professor of surgery at ABC College of Medicine, director of innovation at International Bariatric Club. He's the member of Flexible Endoscopy Committee at SAGES, Bariatric Endoscopy Committee at AFS, editorial board member of obesity surgery, surgical laparoscopy, and the list is unending. He was the first chairman of the Bariatric Endoscopy Committee, which was started by IFSO. And now that committee has been taken over by Abu Dhabi. So he started this basically at IFSO and brought in the idea of bariatric endoscopy. He's the past chairman of Bariatric Endoscopy Nucleus at Brazilian Society of Endoscopy and Brazilian Society of Bariatric and Metabolic Surgery. Manoel primarily is an esophageal surgeon and a gastroenterologist both. But more than that, he is one of the finest teachers. Somebody who would just give. He would never take from anybody. He was just give and go out of the way to teach surgeons like me from across the world. Most of the people like us, mostly like me or many others who are in bariatric surgery, would actually derive a lot of honor and privilege in claiming that he has done so many number of bariatric procedures. But Manoel, I think, is so humble that not only that he has performed thousands and thousands of procedures, but he holds a record in teaching and training and making thousands and thousands of bariatric surgeons like me present here. Thank you, Manoel. God bless you. And again, a formal welcome to you at the virtual Bariatric University Forum. Dr. Amit Maydeo, I'm proud because he is an Indian. He's a Padma Shri and one of the most famous gastroenterologists of the country. He also partnered with me in an endeavor we started together called as Enlighten. He's also trained by Manoel. Amit is the chairman for the Baldeta Institute at Global Hospital in Mumbai. He's a past president of SAGE, emeritus professor at KM Hospital, co-editor of Endoscopy International Open. And Dr. Amit Maydeo has that privilege in the country and that distinguished honor of starting POEM, STIR, and ARMS for the first time in India. He has been a doctor to most of the famous personalities, politicians, film stars, and is one of the most sought for gastroenterologists, not only in Mumbai or Maharashtra, but the entire country. I'm so proud to be associated with Professor Amit Maydeo, and I welcome him to the virtual bariatric university. Both of us have been trained by Manoel, so it's really an honor. It's a very emotional moment for me to be here, and all other friends like Gontrand, Abu, Professor Mousa, and everybody to have on this such an august platform. Again, myself with my mentor and my teacher, Professor Fobi, who made this department, the Mohawk Bariatric and Robotic, of what it is today. And it is because of his guidance, mentorship, leadership, that this department is now the highest volume bariatric center, metabolic center in Asia Pacific, and probably in the entire world. So a warm welcome from his side. Without much delay, we have a very interesting session upcoming, after which there will be a live procedure demonstrated by me and my team. I would like to invite Gontrand, Dr. Amit, and Mousa to moderate the lecture session, the first one. Gontrand, to you, please.
Thank you, Mohit, for your nice introduction and very nice organization of this virtual bariatric university. For me, it's a pleasure to introduce the next speaker. I'm sure the audience is eager to listen to Barham Dayyeh. But I have to say a few words. He's my friend and I respect him so much that if I am going to moderate his talk, I want to say a few words about him. I've been in the field more than 15 years in bariatric endoscopy, and I acknowledge that Dr. Dayyeh is really an expert, an authority, and it's a key reference for all of us in understanding and making effective bariatric endoscopy. He has been a key contributor to our knowledge in the physiologic mechanism of action of bariatric endoscopy devices. His publications, technical and basic science ones, they are a must in bariatric endoscopy. But also about all of this, I can see after being in many debates and co-chair with him in many sessions worldwide, Barham Dayyeh, the professor, is an effective teacher. And I would like to remark his very, very high success in attracting the audience, GI audience and surgeons to the medical field of interest of bariatric endoscopy. So it's going to be a pleasure for all of us to listen about what he wants to tell us right now. Dr. Professor Barham Dayyeh, my friend, please go on.
Thank you, Gontrand. Are we playing the video or pleasure to be?
Yes, Himanshu.
This webinar series. Thank you for Dr. Bhandari and Dr. Fobi for this kind invitation. I'm going to be discussing everything but suturing. As far as endoscopic bariatric and metabolic therapies, these are my disclosures. These are my case mix. Before we start talking about this topic of endoscopic bariatric and metabolic therapy, it's important to set the stage of the unmet need of this disease process. As you're all aware, obesity has reached pandemic proportions, both in the US and globally. Penetrance of therapies like bariatric surgery or medical therapy is still very low because of the multiple barriers there is, and because of the staggering number of population who would qualify for these interventions. Therefore, 99% of the need is not being met currently, and the field of endoscopic bariatric and metabolic endoscopy hopes to supplement the spectrum of care in order to enhance access to effective and therapeutic modalities. Before we talk about these interventions, it's very important to understand the pathophysiology of this disease. So high fat, low fiber diets, including high carbohydrate diets as well, results in a state of insulin resistance in genetically susceptible individuals. This insulin resistance causes alteration in the signaling between the liver, small intestines, pancreas, and skeleton muscle, resulting in a state of systematic inflammation through expansion of visceral fat, through a state of gut dysbiosis in the small intestines, causing leakage of mediators of inflammation to promote the inflamed fat and to promote the state of insulin resistance, with the end product being the metabolic syndrome that we are all aware of. So the major therapeutic goals in devising these interventions is not just weight loss, it's to improve insulin resistance, decrease excess visceral adiposity, decrease inflammation, and restoring the mitochondrial function and the process of autophagy. We could get there through weight loss dependent pathway. A 10% total body weight loss could get improvement in all these parameters, but also in the GI tract, there's alteration in signaling that we're going to discuss that could give some weight-independent metabolic benefits as well. So weight loss dependent pathway relies on losing significant weight in order to alter these parameters. 5% total body weight loss improves cardiovascular and cardiometabolic factors. However, the 10% total body weight loss is associated with improvement in diabetes, cardiovascular outcome, and liver fibrosis. So if we have to have a threshold for weight loss, it's the 10% total body weight loss. Weight loss independent pathways include changes in the by which the gastric glucose or the gastric sugar or nutrient bolus is introduced to the small intestines. This is the curves for glucose excretion after an ingested meal in diabetics, impaired glucose tolerant individuals, and normal. You could see the state of prediabetes and diabetes is associated with increased spike in postprandial hyperglycemia and the body having difficult time handling this glucose load because of the state of insulin resistance. Therefore, one of the weight-independent mechanisms to correct this curve and prevent this hyperglycemia is to delay the gastric emptying, as shown in this cell paper, that the rate of gastric emptying has a major influence on overall postprandial glucose, 35% of peak glycemia following a meal, and also is a major contributor to the hemoglobin A1C. So one of the key mechanisms when you impact the stomach is to delay the gastric emptying in order to have this weight loss independent effect. Also, the duodenum is an important orchestrator of this metabolic signal. And we know in states of insulin resistance, there is physiologic or pathophysiologic and morphological changes in the duodenum that includes hypertrophy in the crypts and villus, including overproduction of neuroendocrine cells, including a state of leaky gut and microbiome dysbiosis, resulting in a translocation of mediators of inflammation to the liver and adipose tissue, propagating the cycle. And also there's an increased absorptive surface of the glucose. Therefore, a target for weight loss independent pathway is to reverse this insulin resistant duodenum into an insulin sensitive duodenum, and that's the target for a lot of the duodenal resurfacing technology and the bypass liner that we will discuss later on in this talk. And finally, altering the bile acid signaling is an important cornerstone of therapies to reverse some of the fatty liver and bile acid signaling with its favorable metabolic benefits. So the goal is beyond weight loss. This is an individual, as you can see, both individuals have same body mass index, and their body mass index were not elevated. However, you could see this individual has a lot of visceral fat versus this individual does not have a visceral fat. So it's not always the target is just weight loss. The target is the reversal of metabolic syndrome, and therefore these weight loss dependent and independent pathways are of vital importance. So endoscopic bariatric and metabolic therapy, the birth of new field, we really needed this field to augment the armamentarium of therapeutic interventions that could target obesity and metabolic disease. The first class of devices are these intragastric balloons. There's different flavors of intragastric balloon approved in the US and the global market. The second device is this transpyloric shuttle, which, as I alluded to, delaying gastric emptying has significant impact on weight and also have an impact on the glucose excretion and the curves of hyperglycemia after a meal. Therefore, this device is designed to delay gastric emptying intermittently after a meal in order to capitalize on both of these effects. The third device here is the full sense device, which excretes pressure on the cardia of the stomach, thus indicating the state of fullness. These are the intragastric balloons that are approved in the United States. The single balloon Orbera, the reshape, which is a double saline-filled balloon, no longer marketed. The Obalon is a series of 3 balloons ingested over a 12-week period and removed at 6 months, and they're filled with a nitrogen gas mixture. Then there's the adjustable balloon, which is the SPAT3, and finally the swallowable and self-excreting balloon, what we call the ellipse. As a class, I said the important number to think about is this 10% total body weight loss. Again, this field has multiple high-quality randomized controlled trials, and they are all summarized here, all with large numbers. And you could see as a group, the intragastric balloons result in a 10% total body weight loss, which is double, triple, or sometimes quadruple the effect that you see with sham or lifestyle interventions. Again, the balloon has an added mechanism of action in that it delays the gastric emptying. As you can see from these curves, from the sub-study through the pivotal trial, is that the gastric retention was similar at baseline. Gastric retention increased significantly after the balloon insertion, continued to be elevated, then returned to normal levels after balloon removal, indicating that that's an important mechanism of action of the balloon. Therefore, we decided to do an FDA IDE pilot study to investigate the impact of the gastric balloon on liver histopathology in patients with true steatohepatitis confirmed by biopsy and MRE or MR elastography. We repeated the biopsy in all 21 patients at six months, and we evaluate the lipidomic signature. All in all, histologically, 90% of patients who get the balloon have improvement in their NAS activity score. 80% had improvement more than 2 points, which is the threshold that we look for effective therapeutics. 50% improved MRA detected fibrosis by 1.5 stage, and 50% reached endpoints approved by the FDA for NASH resolution and fibrosis regression. So the balloon, at least the Orbera balloon, has been very effective in the treatment of NASH. Now, the hype recently was related to intermittent fasting, and you could see intermittent fasting could correct a lot of the signals originating from these organs and the metabolic stress associated with these signals. Therefore, strategies to enable patients to do intermittent fasting are important ones. This is the full sense device, which we're investigating with our colleagues at AIJ in India. Basically, this device is calorie agnostic. That means this device puts pressure on the cardia of the stomach where there is no food in the stomach. Thus, it will be a perfect device to marry with an intermittent fasting strategy to allow the patient to fast for 20 hours a day and eat for 4 hours a day without feeling miserably hungry. And that comes with a lot of weight-dependent and weight-independent benefits. This is the picture of the device. It does not bridge or interfere with the GE junction, as you could see. When we go into the retroflexion use, you could see the device is exerting pressure on the cardia, activating these mechanical receptors that convey signal to the brainstem, indicating satiety. Therefore, there's a lot of excitement around this concept. The final category in the gastric devices is this Aspire Assess device, which is a special modified PEG tube that you place in the stomach, and it allows you to aspirate about 30% of the ingested meal. This device did clear a pivotal randomized control study in the US, and you can see that the results are very, very good as far as reaching this 10% total body weight loss thresholds. And we have now data that extends that as long as you use the device, this effect could continue to be materialized. Now, Dr. Alqahtani will talk about the gastric remodeling techniques, which is a whole topic by itself. Therefore, I'm going to skip to talking briefly about small intestinal devices for the sake of time. So small intestinal devices their task is to kind of reverse the clock on this duodenum, taking this insulin-resistant duodenum that interacts poorly by these interacts unfavorably with these peripheral metabolic organs, and reverse it to an insulin or metabolically healthy duodenum that is insulin sensitive. So the first category of devices is these duodenal liner. This is coming from a company in Minneapolis called Bariatric, that allow you to deploy a liner that bypasses the majority of the duodenum into the jejunum using these lumen opposing stents. This device has the advantage in that it does not have any traumatic edges to it compared to the GI Dynamics device. This meta-analysis is from the GI Dynamics device, which showed that the device and the concept is effective with a significant improvement in A1C after the intervention. This is the interim analysis of the pivotal US trial before they stopped this trial because of the risk of hepatic abscesses with the Endo-barrier device, but nonetheless, in a large sham control, 213 patients, the A1C improvement was 1.07%, with about 8% total body weight loss, indicating that the concept works. And again, this is the difference between Endo-barrier and sham. As far as A1C improvement, highly significant, even with stopping the trial early, but the liver abscess rate was about 3.48, and now the company is trying to change direction, and they're in the midst of a second trial with this device. Valen Tx is historic perspective. I don't think it's being pursued anymore, but the idea is to bypass the stomach and the small intestines with one device. There has not been much newer studies reported on this concept, and I do not know where they are in the development process. Again, these are the two liner. You could see the difference between the traumatic and atraumatic version of these, as far as the anchoring mechanism in the bulb versus in the pyloric channel. So shifting gears to ablative techniques, and there's a lot going on in this area because, again, we could take a diseased duodenum, reset the signal by ablating it, and reset the stem cell niche as well in order to have a healthy insulin-sensitive duodenum. This is not a foreign concept in GI tract. I mean, we take a diseased esophagus with Barrett's esophagus, we ablate the Barrett's esophagus, and it comes back as squamous. So therefore, this has been the target of lots of investigation. And there's companies now that would use laser to do this, companies that would use heated water, which is fractal, in order to do this. And the newer kid on the block is company that you do not use any thermal injury. It's called pulsed electrical field in order to introduce pores in the cells of tissue that the tissue would die through programmatic death rather than through a coagulative necrosis effect. So finally, there's biliary diversion and endoscopic anastomosis techniques. This is GI windows. There's two flavors currently of this intervention. One is that connects the jejunum to the ileum in order to divert bile and capitalize on the bile acid signaling, and the other one that connects the duodenum to the ileum through this laparoscopic endoscopic approach. More to come on these procedures, and they will offer some significant advancement for the field. Just to put back the spectrum of care of what we discussed today, I plotted to you all the intervention from medical to surgical, and what the patient care about is this 10% total body weight loss. So you could see with a lot of the intragastric balloons, the majority of patients reach that threshold. Aspire as well, endoscopic sleeve gastroplasty that gets closer to the lap band level. So you could see that with the advent of new medications, devices, and surgeries, that now we're having augmented and supplemented standard of care. So what's the future, my friends? The future is we need to embrace these technology and use them. This is the AGA. They're going to issue an practice guideline for the use of intragastric balloon for the treatment of obesity and metabolic syndrome. Again, the societies are recognizing the values of these intervention, and hopefully we could continue to push the envelope for reimbursement and offer some significant real options to our patients in combination with a healthy lifestyle, of course, and pharmacotherapies. Again, New England Journal of Medicine just published the results of semaglutide at a dose of at a 68 weeks period through a weekly injection, and the agent was very promising in a large trial, showing weight loss in the neighborhood of about 14%. So imagine now you take a endoscopic gastroplasty or a balloon with Endo-barrier, and then to induce weight loss initially and reversal of obesity-related comorbidities, then you combine them either in tandem or in sequence with a drug like semaglutide, using repeatable therapies, combinable therapies, sequential therapies, enhanced and finally personalized. So that's the key. Is obesity is a chronic relapsing disease with no cures. And therefore, we need to start strategizing which patient benefits more from which strategy and keep that spectrum of care fluid to manage it as such as a chronic disease. So also part of the future is this robotic platforms that are going to come to endoscopy. Obviously, this is still in early stages, but here in an ex vivo tissue model where we show the concept that you could do a wide EMR, wide endoscopic submucosal dissection, and then that would enhance the plication of the sutures for bariatric indications. And here we're suturing that together in order to demonstrate this concept. Again, this is all done through an endoscopic platform, which is, there's significantly advanced. Here you can see the gastroplasty coming together very nicely for more durability. With that, we conclude that the GI tract is front and central in weight and metabolic regulation. Endoscopic bariatric and metabolic therapy will play a major role in the management of obesity and its metabolic complications. The future is quite bright, and collaboration with all the team members is the path for success going forward. And with that, I could conclude and take your questions.
Thank you, Barham. Thank you very much. Very, very clear. I'm a little bit astonished that the future is intragastric balloons. Once we started with balloons 20 years ago, but again, intragastric balloons, they are in the spotlight, maybe because they are the most simple device that we have and safest one. So I'm going to address a question for you. When you talk about medical devices, you have shown many of them. You talk about the concept of delaying gastric emptying, which is key. Understanding how these devices work, but I want to listen your opinion about what is at the end the most clinical important thing for us, which is hunger. We understand delaying gastric emptying, you can then enhance or ameliorate the insulin resistance, but what is the impact of hunger in all of these gastric devices or small bowel devices, or the combination of them? Because at the end, the team of all of us want to deal with patients with no hunger or diminished hunger. What's your opinion on hunger in all of these devices?
Yeah, so thank you, Gontrand, for that question. So hunger is a complex phenomenon that involves gastric and small intestinal pathways. The immediate hunger terminating signals are coming from the stomach, and these are related to the accommodation of the stomach after the ingested meal and related to the rate of gastric emptying. So that's what governs the two processes of hunger, which is satiety and satiation. However, that's the first step for the immediate phase of hunger. But then intermeal phase is dependent on the gut sensing mechanism of the small intestines, releasing the anti-hunger hormones like GLP-1, PYY, all the others. So it's a complex interplay, and you could see with these tools and techniques, we will have both the ability to impact gastric pathways that govern hunger or satiety and satiation, and also small intestinal pathways through bile acid circulation and targeting the proximal small intestines. So everything we do here will have an implication on hunger. And it's the question, is it during the active meal phase, so terminating the meal phase, or it's in between meals, or now even with the concept of the full sense is eliminating hunger in an intermittent fasting period to allow the body to benefit from that. So that's these are the multiple mechanisms, Gontrand, and I think we're capable of targeting most of them. Okay, another quick thing. So you have talked about that at the end when you explain about, for example, liners or small bowel therapies. At the end, you talk about total body weight loss. We have said that for example, Endo-barrier has an average of 7.7 of total body weight loss at 1 year, for example. So my question is about, again, gastric devices, balloons or endosuturing in the stomach, as they are able to induce a double total body weight loss, for example, than the small bowel therapy so far. So are gastric devices enough for revert metabolic syndrome or for weight loss? Are they enough, or you think it's going to be mandatory to combine? Yeah, that's a very good question. Gastric devices are enough if they're durable. Balloons are temporary, as you understand. So balloon is good to get a disease into remission, but they're not a durable strategy to maintain the weight loss over time. Therefore, if you want to augment a balloon, you could put a balloon, you could get the metabolic disease under control, you have patients lose significant weight, but the balloon should be followed with a pharmacotherapy intervention. And that's where semaglutide seems to be a very good one, because it will peak the GLP-1 similar to bariatric surgery. So having a gastric intervention followed by a pharmacological intervention could be more than enough to get things under control. Now, there's going to be different responders and non-responders to each intervention. And that's why having all these options will be helpful in figuring out how could we match the device or the medication to the physiology of the patient. And that's going to be the next phase of investigation, is how to do this.
Okay, perfect. Thank you for your answer.
So Barham, I have one, Gontrand, can I ask one question to Barham?
Sure, Amit, sure.
Yeah, sure, thanks. Barham just said that to improve the efficacy of the balloon, you have to add pharmacotherapy, especially for a metabolic syndrome sort of a situation. Now, I want to know, how long do you continue the pharmacotherapy?
So
how long do you?
So in an ideal world, we give the patient a balloon. Now there's different indwelling times, but after you're planning to remove the balloon, usually a 2 week before removal of the balloon, we start a GLP-1 agonist. And that we remove the balloon, and now the GLP-1 agonist is at a full dose, complementing the balloon. And the plan is you need to give it enough time for body physiology to adapt. So usually I try to keep it at least 2 years as a management strategy. So the balloon plus another year of medications, and see how the patient does. And hopefully by that time, they would have adopted new behaviors and new healthy habits to continue with this. The problem with medications, to be honest, is they will need to be taken forever in order to work. And the moment you stop them, their effect goes away, and there's some tachyphylaxis. That means there's some resistance that developed to these medications. So medications are improving, but cost is a limitation. The fact that you need to take them lifetime is a limitation, and the fact that they lose efficacy with time is also a limitation. However, a paradigm that, like the AGA suggests, where you start with an initial weight loss phase, and then you go into a weight maintenance phase that involve medications and other devices, bariatric surgery or what have you, is important. That means these patients will need an effective therapeutics at any point in their lifetime. And there's no time that you're not managing the disease. You're always managing the disease of obesity, just like hypertension or diabetes.
Okay, go ahead, Gontrand.
Yeah, anyone have another question? Otherwise, I have a couple more to Barham. We have to, please, Barham, be quick. So one is a very simple question. If you say, everybody says when we talk about duodenal resurfactation that, okay, if insulin sensitivity is in the duodenum, we can impact there doing duodenal resurfactation, but I don't understand. If we ablate the duodenal tissue, we burn it, or we ablate it, how do we really improve this sensitivity to insulin? First question.
Yeah. So you're asking about the mechanism of action of the duodenal resurfacing. The mechanism of action is multifactorial. We still do not understand it fully, but it involves three things: decrease the absorptive surface of glucose and sugars in the small intestines, because there's hypertrophy with insulin resistance in the duodenum. Two, corrects the dysbiosis in the small intestines that dump mediator of inflammation to visceral fat. And the visceral fat inflammation causes release of fatty acids into the liver, and skeletal muscle causes this insulin resistance. So all in all, we still do not know fully the mechanism of action, but we know that the concept works. And the question is, how do we do it efficiently and cover a bigger surface area than the existing technology allows us to do?
Okay, and last quick things, just tell me your opinion. Imagine a patient has lost 15% of total body weight loss, 15%, and you have to decide in an arm or a sequential balloon, another 9 months of balloon, for example, or 1 year of GLP-1 agonist medication. Which one would you select? And which one do you guess the patient will select?
With the balloon, I would embrace a strategy where a balloon followed by GLP-1 agonist, because that's the strategy that makes the most sense to me. And if you are responders to a balloon, your chances to continue to respond to GLP-1 agonist is high, because GLP-1 agonists also delay the gastric emptying. So they're complementary plus additive benefit of this combination. So that's the strategy I would go with for this.
But
patient.
if you have to choose just one, or medication 1 more year, or a second balloon 1 more year, you can not combining. I said one or the other. So are you fond of a sequential balloon, second balloon?
I'm not very fond of sequential balloon because it's without a period of honeymoon. You have to reset the stomach before you put the second balloon. And removing a balloon and putting one immediately is, I don't think is a good strategy because your stomach needs to reset before that. Therefore, I'm fond of sequential balloon with the separation in time between them rather than immediately. If you're looking at an immediate strategy, I'm fond of balloon followed by a medication immediately.
Thank you very much.
Go.
Yeah.
Yes, Mousa.
Yes.
Yeah, hi, Barham. A great talk. I have a question for you. What do you mean by resetting the stomach after removing the first balloon? In our experience, if you remove a balloon, you see a dilatation of the stomach, and all those sleeves that we do or bypasses, we notice that the size of the stomach increases tremendously in comparison to people who did not have a balloon prior to surgery. So what do you mean? Do you mean that the stomach will shrink after a while, after removal of the balloon?
Yes, and that's the concept, Dr. Khoursheed, is the stomach will get smaller and thinner with time. That's why we recommend that after you remove a balloon, if you're contemplating going to bariatric surgery, you wait a period of at least 3 months before you go to bariatric surgery to allow the stomach to reset. That's the same concept. If you're contemplating a balloon after balloon, it doesn't make sense to put the second balloon immediately, because the stomach has already got used to one balloon, unless you're changing its volume, of course. So if you're doubling its volume, that's something different. But you allow the stomach to shrink back, the wall thickness of the stomach to get thinner, and then you introduce the second balloon if you're going to embrace that strategy, and that takes a few months to happen. So you cannot use the immediate time point for that matter. Therefore, adjustable balloons have an advantage there, is you could change the volume to accommodate for that. But that's a real phenomena that the stomach needs to reset before a second balloon goes in there.
I doubt this happens in our patients, at least in our experience. We've seen patients after longer than 3 months, even at 1 year, and the stomach size never go back to its previous size. So we noticed that even the number of staplers that we use to do the sleeve are much more. So this is at least in my experience. I don't know whether someone else is having the same experience.
On my experience, Mousa, you can see that in some complicated balloons that they have intolerance, or they overdose medication to stop motility, for example, Buscopan or something like this, you can see dilation of balloons, of stomachs, and you can see the diminished tonus of the stomach, the muscle tonus. But in most of the balloons that we remove, I could say that endoscopically, we cannot guess if the stomach, so we see a normal stomach in most of them. So in the uncomplicated balloons, we just remove it because they are on date to be removed. Stomach looks normal. It doesn't look so dilated.
And we have also objective evidence to support that. Remember the graph I showed you about the effect of gastric emptying with the balloon through the randomized trial? About 4 weeks after removal of the balloon, the effect reverses. That means the balloon no longer delays gastric emptying, which goes with the idea that all these changes that you see are reversible after the balloon. But the idea, if you want to embark on a sequential balloon strategy, you're better off to separate it in time until the stomach resets a little bit than putting sequence.
To support Barham idea, we have seen this, and this is why we don't do laparoscopic sleeve gastrectomy after balloon and let's wait for about 2 months or more, because for this changes that happens, and you see it, if you wait 6 months or more, you'll see the stomach almost going back to normal in terms of wall thickness, motility maybe, but you can figure it out. The minute you enter the abdomen, you see complete different texture of the stomach wall, like the striations and the illustrations in the wall, and the normal texture disappear, replaced by almost floppy-like stomach. However, most of them are reversible if you wait with time.
Okay, Amit, let's move on to the next talk. Dr. Maydeo. Professor Maydeo, you're supposed to introduce Aayed.
Oh, I'm supposed to introduce, because when I asked them, they told me I don't have to introduce anyone, but it's my greatest pleasure to introduce Professor Aayed Alqahtani, who probably has one of the largest experiences in the world on endoscopic sleeve gastroplasty, and he has published his phenomenal work. So let us hear from him about various primary and secondary endoscopic plications, about ESG and stoma reductions, pouch reductions, etc. So Aayed, please go on.
Thank you. Good afternoon, and thanks for the invitation. Glad to be with you today. We'll talk about primary and secondary endoscopic procedure for weight reduction. This is my case mix disclosure. Endo-bariatric is really growing fast, and it's involving small bowel and gastric intervention. And usually it starts from a system mimicking bariatric surgery, can be used primary, secondary, as a revisional, or to treat complication. When we look to the mix of utilization of endo-bariatric, it's really huge. And I think it's very important in the practice of bariatric surgery. You can see from volumes to revision to fistula to primary to stent to others. When we talk about mostly primary, we are dealing mostly with gastric interventions. And today we'll concentrate mostly in endosleeve or endoscopic gastroplasty. Small bowel, we will not talk about it. It's not part of our talk today. Usually the overstitch system that we utilize to do endoscopic sleeve gastroplasty is mounted to double channel or single channel, and this is the way it is mounted to double channel with the system. Again, it's available in a single channel here recently, you can see, and this can work also with different type of scopes. When we go in with a double channel or a single channel system, you go in this gastric wall with the whole system, try to take full bite. You create your type of sutures in a U-shape or square or other. And your aim is to have a sleeve-like stomach, as you can see here, where it is very well tightened to the point that's almost reaching up to 70–60% of the stomach lumen. Very important not to be too tight, and also not to have it asymmetrical. Being symmetrical is really critical in minimizing the symptoms, and also maybe contribute to durability of the procedure. These are the type of pattern that can be created: square, U-shape here. Different bites. We can take 3 bites in each row, or 4, or it depends on how much you would like to. You need to have the tissues close to each other, and there is no pouch, and there is no significant distance between each bite. Or also triangular, as you can see here. There are new like a type of pattern, Z pattern or zigzag pattern, where you can really go distal to proximal. Again, patterns does not matter more in terms of weight loss. Most importantly, to have very good symmetrical sleeve-like, and really no pouch in between. This is the way it looks from outside. And you can see you are really taking full thickness. And if you really tighten the whole stomach from outside and inside, you should avoid the tissue around you. You can see the suture here is full thickness. And end of the day, after finalizing the procedure, you'll see it from one side as full sleeve-like shape of stomach. We have done till now 3,000 cases and follow up to 3 years, reaching 14.3 total weight loss. Similar results has been obtained in systematic review studies, where it shows up to 60% excess weight loss at 1 year. The Brazilian consensus showed similar result, 18% total weight loss among 47 endoscopists. Is it durable? This study from Bariatric team up to 15.9% total weight loss at 5 years. So yes, it can reach to 5 years. How is it compared to other type procedures? I think it is better and it should be positioned between the sleeve and the band. It's better than the band, and it is not better than sleeve in terms of weight loss. We are talking safety and others, definitely it's better than both. We compare our result, as you can see here, 11,000 sleeve to 3,000 ESG or endoscopic sleeve gastroplasty. The weight loss almost different by 7 kilograms at 2 years. This is only in terms of weight loss. There are other parameters that we are comparing. It can be used in pediatric, and 1 year and a half, we maintained almost or obtained 15 total weight loss. And we have almost now more than 200 children who underwent children adolescents underwent the procedure. It can be also very effective in diabetic patients, and you can see here it's similar to bariatric surgery, where it is more effective in those who are on oral hypoglycemic, and if they are on insulin, it is less effective. It can also result in resolution of hypertension and other dyslipidemias and others. It's really safe procedure if you compare to other type of intervention, but in general, in our experience, almost every complication in terms of fever, perigastric collection, bleeding, less than 1%, 0.5, 0.2. In this systematic review, total overall complication rate 0.2%, ranging from bleeding to perigastric collection. Perforation is rare, 2% cases or 2%. And severe abdominal pain, this is very common, but to the point that really severe to affect the patient in a way or another is not that significant or not that common, but most of the people will complain from nausea and vomiting that can be managed either at home or they come and take some analgesia, intramuscular or IV. The good things also, it can be reversible, as you can see here. And if you look to these switches, you can just go and cut them. Even in the bridge here, you can see this bridge, you can just cut it, it will open. So don't, in our experience, every single patient can be reversed. Every single patient does not hold in terms of being fibrosed or so. You just go there and cut the bridge and it will open. The good things also, it can be redone again. You can redo ESG. This is a patient who has been seen after ESG, and we went again to retighten the endoscopic gastroplasty by applying more sutures in between the previous sutures that have used. So you can see here, we are choosing our places in between and we are tightening. You don't need to remove the previous sutures unless you think it's causing granulations or granulomas or others, then you can remove it. But otherwise, you retighten it, and when you look at it at the end, it's really almost similar to as if you are doing it the first time. Can we use it as a weight regain intervention for revisional procedure? Absolutely, yes. So weight regain is usually defined by regaining more than 20% with the maximum weight loss. There are other definitions, but this is the most commonly used. And most of the sleeve patient or bypass, there is a rate of revision for whatever reason. But the most commonly or the most common reason for revision in both sleeve is for weight loss, for weight regain, and similar to bypass. And you can see here there is up to 37% they can regain their weight, different studies and different reasons. So we must have the tools in our hand to help these patients to solve their weight regain and less invasive and easier approach other than surgical intervention. You can range from ablation alone to suturing and ablation to different type of tools. For sleeve, this is for bypass. There are different tools. For sleeve, you can do ESG, endoscopic sleeve gastroplasty, post sleeve, and I'll show you some videos and results. Also for banding, we can do it. There are some people believe you shouldn't do it in banding. No, you can do ESG in patients with banding. This is a way to ablate, but in general, it starts from evaluation to ablation to suturing to follow up. In follow up, it's very important to give them certain protocol, but in general, when you suture here, you can do it either interrupted simple, or you can do it burst ring. It seems to be burst ring in different format is more effective or durable, or at least give you better weight loss. Pouch, yes, can be reduced as well in those who are having pouch dilatation. But importantly, you should pay attention to those patients who are vomiting, nausea, and pain. Controlling pain and antiemetic utilization is very important to give better durability for the sutures. The durations or durabilities of TOR in 2 years, it reached to 8.6 total weight loss. It can go also to 5 years. And this is where you can reach a similar weight loss at that time. In terms of this algorithm was suggested by Harvard, a group where they say if it's more than 5 centimeters, maybe you need to tighten this pouch, reduce it. If it's less than this, less than 5 centimeters, then you go for the stoma suturing and ablation maybe. In our experience, only 6 kilo weight loss. It was not very effective to only suture the stoma or reduce the pouch. And it is something you can use, but don't give a lot of emphasis or a lot of hopes on that unless you combine different options. This is where argon plasma come in to help either on its own or with suturing, up to maybe 10% total weight loss. If you compare it with control, yes, it's better than control. If you only ablate the area, 1 centimeter ablations all the way circumferential. Maybe using high dose will result in high voltage, maybe will result in better result. If you compare it with add ablation to full thickness and ablation together, better than ablation alone. There are multiple studies that has compared different techniques. Combination is definitely, summary of all, combination is better. Combination, whether ablation, whether suturing and ablation, whether endoscopic mucosal dissection. And again, endoscopic mucosal dissection, you can see here, will result in durability of the suture. If you don't use endoscopic mucosal dissection, maybe the duration and durability of the suture, they break easily. Similarly, if you add suturing and ABC or endoscopic and suturing because of the submucosal dissection, maybe submucosal dissection is better than ABC to be added to the suturing. So, different combination. If you put it in cocktail, you'll say suturing plus endoscopic submucosal dissection better than ablation alone or ablation with suturing. There are different ways to ablate by cryoablations. It works, but it's not as good as the other tools, definitely. Radiofrequency, again, has some effect, less than others. Then we come to sleep. What can we do for patient to regain weight after sleep? We can do ESG. This is the ESG as you can see here. This is very short video to show you, yes, you go in and you suture it as usual, as if you are dealing it with a primary. Don't worry about thick tissues or anything. Just do it as a primary procedure. You are okay with that. You will have this result as tight both, but the weight loss is not as primary, definitely. This is what we tell our patient about 10 kilogram weight loss we expect. This is the result we have done with our friends from Mayo Clinic and other centers, where you can lose up to 10% total weight loss at 1 year. Again, from Brazil group, this is up to 70% excess weight loss at 1 year. In band, this is the last slide. In band here, you can see we can go in, retroflex, evaluate, and then you can switch her as well. Same thing. This is the band ring here. You can see you pass through the system, deflate your band before, deflate the band, the fluid there, take it out. Then you go in with your system, you do your tightening, and you will have the same result as we have shown you in other videos, and the result will be the same. So, conclusion, ESG is an effective and safe primary weight loss procedure. It provides a middle ground solution between lifestyle behavioral modification and bariatric surgery. And I think it's very important for those who are not yet candidates for bariatric surgery, or those who are rejecting bariatric surgery. As a revisionist, it's very important and effective, as we have shown you, result in significant weight loss up to 60% excess weight loss or 15% total weight loss. And it is better if you give me a choice to have something less invasive, less complication as primary revisional procedure, as just primary intervention before major surgery, I think it's important to choose less invasive as endo-bariatric. So endo-bariatric is really here to help us as bariatric surgeon or gastroenterologist or any people who are using this endoscopics to overcome a lot of problems with their primary or secondary issues in terms of weight loss or complication. Thank you.
Okay. Amit?
Yeah, thank you very much, Professor Aayed. It was a very, very comprehensive talk on this topic. I just want to ask you one question for the audience who is going to begin doing endoscopic sleeve gastroplasty. So as an expert in ESG, can you tell us some technical tricks how to improve the durability of your ESG, durability of your reduction in the size of the stomach, as well as the result of your ESG by adding any pharmacotherapy? Do you do it in all the patients? And what are the technical tricks do you use to improve the sleeve to make sure that it is durable, it lasts for a longer time?
Absolutely, it's a very good questions, and I think let us see here. Yes, I think it's very an important question because the durability is the question nowadays. And the most important, in my opinion, is to take your full thickness bite and close to each other. Bite are close to each other. When you tighten them, they are symmetrical. You are not twisting the stomach. What will break the switcher? Will break the switcher if they are asymmetrical and there are pressure created by having the stomach to go back to its normal position, or having frequent vomiting because of this asymmetry in the stomach or so, and that will create intragastric pressure that will make these switcher under tension. Or you tighten them so much that you want to get them closer, and you will, with time, they will cut. We have seen many times the needles and the anchor penetrating the wall because we are really, and that's normal. When we are starting in the learning curve, we try to make things very nice and tight and neat, and that's the end of it at that day. At the end of the day or end of the month or so, you will have these anchors or needles going through, switcher under tension, and anything that will be exerted on this switcher will make it easy for them to cut. So I think make them close to each other. Try, and okay, the patterns is important, but you will create your patterns while you are going through your procedure. You will know you want to create that symmetrical stomach, banana-like stomach, going all the way, so you know where the first bite, second bite, and accordingly you will go. So that's my message from what things will make the suture durable. The other things to avoid complication, which is very important, try not to go. I know in the beginning, in the interim, we will go 3 turns of the helix. But maybe when we are going in the body or so, you can throw 2 turns on this wall and then pull them all the way towards you. And then you throw the other 10 if you want to have more tightening on the wall, because you want the wall to be fully with you, full thickness, but also you don't like to catch something around. And we have monitored this, as you have seen in the videos. We monitor it from outside. So the wall, especially in the body and the pandas, just 1.5 or 2 turns, easily you will be almost outside the wall. So trying to be in that level where you put a first turn of the helix and second, and then try to pull on it. If it comes easily, you are okay. You are still in the wall. You can throw another turn while it's in the air coming to you, or you are pulling on it. So these things are important, I think, in avoid complications.
But do you add any pharmacotherapy with your ESG?
Interrupted.
Or you don't give any?
Interrupted, there are systematic reviewing we're adding reinforcement or no. I think if you do them, I think it will work. I think it might be added or might have added values. And I know there are some studies now on it. And then Barham is, I know he's also from the team who's supporting reinforcement. I don't know Manoel and Gontrand, but I don't think there are a lot of parameters. We have to justify that reinforcement will add to the outcome by evidence-based medicine to show that it will add to the outcome, because it is adding a lot of time in the operating room. So is this really worth it to add 1 or 2 or 3 reinforcement, and that proven to will be that it will affect the outcome? We don't know. So we have to justify this and prove this, that yes, it will add to the durabilities. Then yes, it's worth it to spend more time in the operating room, more money for the patient, and because so each switcher is costing a lot of money. So I think in our practice now, we do 4 to 6 average switchers per patient, and we will put them closer to each other in a square pattern. And we think the outcome is okay with that. What we have in our practice is fair with everybody else, even those who are putting reinforcement. So I'm not supporting reinforcement currently, unless I see evidence that it will have some difference in the long term.
But do you give
We
any?
do the same, Aayed,
pharmacotherapy?
we do the same.
Yes.
We do the
Go ahead.
So do you give any liraglutide or any other pharmacological?
What we will do initially, as Barham said in the balloon experience, we don't interfere with additional things until either they plateau their weight loss and there's still the need to lose more. Our experience, and this is what we tell our patients, the first 3 months, 4 months, you will lose around 15 to 20 kilogram, almost the average, especially depends on the weight they have. But that's the average we tell our patient. Expect in the first 3 to 4 months, you will lose about around 15 kilogram, maybe more based on your original weight. Now, after that, some of them will continue losing, and some of them will plateau, and some of them will be happy with that weight loss, and they are okay, so we don't add. When they come back to us, we reinforce the diet experience. I always tell my patient, 50% of the success on you, 50% on the procedure. So please understand this from the start. If you cannot commit yourself, you know you will fail. And then we'll see, it's 3 months, 6 months. And then when that's plateau and they are not happy with their weight loss, then we add either GLP-1 or other type of medication to help them to lose weight.
Good. Very good. One last question from my side. It has been my experience that those patients who have undergone a lap sleeve gastrectomy, when you do a revision endoscopic sleeve, we find that the stomach wall has become very thin because the outside supporting tissue of the stomach is cut off during the LSG. Now, do you think that when you are doing a revision after endoscopic, do they bleed more, or do you tend to have a little more complications?
Not really. Usually the gastric wall, yes, it's this detached, but everything detached will go back again. There will be more fibrosis, there will be more thickness. In fact, when we go for helix in the turn, we go 3 easily, in revision case, because we know the wall is thick and you need to tighten it a little bit with the small volume that you are in. So we honestly, this is why I said in the video, don't bother with its primary or second. It's a matter of finding what is the most important in EST post sleeve. That is the configuration of the sleeve you are dealing with. You will find antrum is really pouching in a different way. The fundus is different way, and maybe there is a pouch in the body. So it's not symmetrical sleeve to start with. So you have to figure out where to put your suture accordingly to create a new symmetrical sleeve after EST. But in general, don't worry about the anatomy or bleeding being different than primary. This is not what we notice in our practice.
Okay, thank you so much.
Good.
Anyone else wants to ask?
Yeah, can I make a question, Dr. Maydeo?
Yes,
Yes, of course. Please go ahead. Gontrand.
Thank you. Aayed, very nice presentation. And I want to focus or highlight something that you have said about what can we do for make this endosuturing, which is fantastic, but our main problem of all of us is it doesn't last as much as we would like it. So we have been, Manoel, I'm sure he remembers this, we have been talking about suturing patterns since 2012 and 2013. Of course, any doctor will talk about his own pattern, saying that is the best one. And finally, we don't know. At the end, we think that the procedure time is very important because it's related with insufflation of the stomach. So if you are a quick doctor, I know, Aayed, you are very quick, the sutures are not under tension and will last longer. How many of your plications are full thickness is key. Also is key the position of the patient, because if you have all the liver, for example, or all the right side of the patient going into the stomach because you do it too much in left lateral. So this is going to be important in the distension of the stomach. So these kind of things, and the ability, of course, of taking full thickness bites, at the end, I guess, is more important than if you do a U shape or you reinforce. Everybody reinforces. When you see that your last suture is not good enough or you can do it better, you reinforce. Sometimes you see it goes well, it's smooth, and you don't reinforce. So I think we have to maybe come back to the basics of all of this and think what we can do to enhance the sutures. I don't know what is your conclusion yet after so many thousands of patients done.
Absolutely true, Gontrand. That's exactly, bottoms doesn't matter as much as what you do inside when you are doing your techniques.
All right, Professor Khoursheed, go on.
Yes, can proceed.
Mousa?
I'm here.
Go ahead and introduce the next.
Yeah, it is my pleasure and honor to introduce, I would say, my mentor who taught me how to do the ESG. Manoel has been traveling all over the world, teaching people different techniques, and he has been, as Mohit has mentioned, Dr. Bhandari at the beginning, this guy has been offering everyone the help to and support. He has been to Kuwait many times. He has been doing with us many workshops, and he's going to give us a very interesting talk. I don't know whether he is going to cover this talk in this session, but this is a huge talk on endoscopic re-intervention after bariatric operation. So we're looking forward to hear from Manoel. Please welcome Manoel.
Himanshu?
Greetings. My topic today is going to be about endoscopic solutions for bariatric surgery complications. And thank you very much, Professor Fobi and Professor Mohit Bhandari, for the invitation to be here among you in the virtual Bariatric University episode 18. And I'm start introducing to you the team I work with in Brazil, Eduardo, Thiago, and Gustavo, that my job looks good. Bariatric endoscopy is a very mature field in my country. You can see here by the publications that we have. And specific about complications in bariatric surgery, though the main procedures are the sleeve gastrectomy, the Will-wide gastric bypass, and its variations, and adjustable gastric band. And because this topic is so vast, I will focus specific on the sleeve gastrectomy complications. And I always like to start saying to you, the bariatric surgery is as safe as lab coated, and nothing that I'm about to say will contradict it. So sleeve gastrectomy, the most prevalent procedure worldwide, most done procedure worldwide, and they have two specific complications. One is stenosis and stricture, and the other is the sleeve leak, and they behave in a very, very peculiar way that I will guide you to. So sleeve gastrectomy, it is done, so you just staple through a bougie as a roll, and then sometimes it's easy to recognize, sometimes it's not. Most of the patients come to us 3 to 4 weeks when they cannot progress to solid food and complain about reflux. Sometimes it's easy to recognize, sometimes it's not. Different from all kinds of stenosis that you have in the digestive tract, that if my scope doesn't pass through, we have a true stenosis. In that case, the scope will pass through, and I'll guide you through that. So we first described in around 2010, our group described the pneumatic dilation to treat this complication. It's changed the way it was approached by surgery at that time. So this main treatment using a specific balloon dilation, you can see here is pneumatic one, and you can see by your own eyes on the screen. So how we can really approach endoscopically with a very aggressive dilation, and how effective it is. You can see here in that paper that we could achieve with patients that complain about the symptoms or have symptoms of stenosis, and then we investigate them, then we treat by dilation. We could get 88% of success rate, 70% balloon alone, and more 17% if you add on this workflow the stents for the non-responders. And also, you can see here this recent systematic review our group did with so many papers that we get to that about stenosis, and we get that endoscopic treatment is the most successful one. And among endoscopic treatment, pneumatic dilation is the most successful one. So this is one we can clearly recommend to start treating this kind of complication. And leaks. So the leaks, you see, is very, very peculiar. So what leads, what causes these leaks? Most of the time, as you can see here, that is an axis deviation stenosis on the caesura. It impacts on the pressure, they have a weak spot at his angle, and then they start the leaks. And different from leaks from gastric bypass, for example, most of the leaks with sleeve gastrectomy tends to become chronic. So what are the options? So you have very good news that have very effective ways to treat the leak, and not that good news because we still don't have a raw treatment. But I'll try to show to you what we have. So you see here this very important paper, this sleeve consensus that we take part of. They define a classification in acute, early, later, and chronic. This is the most used classification in all the papers that follow this one. And you can see here what the options. So one of the very first one was the stents, and what the literature say about the stents. So if you see here this meta-analysis from São Paulo University, you can see here how many papers were reviewed, and this meta-analysis could identify 24 studies, 187 patients with a bariatric age, with bariatric BMI, and the overall success rate of 72.8%, even not using specific stents. And you can see here on this meta-analysis graph, if you follow the losango down below, you see that is a very comfortable success rate for that. And leak site, as you can see here, 95% of the leaks are proximal, meaning his angle on that. And most of the ones treated by the stent, they are in between acute and early, that correspond to almost 80% of this series on that. And Then comes what you can see here. The average stents per patient is 1.4, so expect to use more than one stent. And you can see here the days, 3.3 days just after the diagnosis of the leak, so using by acute, and stay for around 1 month. But the Achilles tendon is the migration rate, as you can see here. And as it is a meta-analysis, the flaws of meta-analysis that we don't include case series, and all of these reports, they're small series. There's no data on fistula size, no reported perforation, no bleeding described, and no deaths reported, and we know they are all happened. And we can achieve very good success rate with customized stents, bariatric stents. They're different from esophageal, they are longer and wider, specifically designed for sleeve leaks. You see here, we can go in this series we did in Brazil, 18 patients, 100% success rates. And you can see here that the trade-off is that the patient gonna feel a lot of adverse events like nausea, vomiting, pain, but you can control that. So what happened when you use these is you can even control the migration rate. But what happened with the same kind of stents? You go multicentric and you involve centers that are not fully dedicated to that, but they use the stents. So you can see here different type of stents, very well designed, that can cover the leak hole, pass to the incisor, so they occlude the hole, they take down the pressure, and you can see here from A to F how the leak it is. You pass the stent, you occlude everything, and we got in this series 78% of success. But what happened with those stents is that you can have complications, as you can see here. You can have pleural fistulas, you can have dislodgement that needs surgery, you can have contained perforation, and even submucosal abscess on that. And that recently we see from France 5 cases of aortic injuries. So that's the trade-off. You have really to take care of those patients and follow those patients. Another option that's good one is the pigtail stents, comes from French. And you can see here, you put by endoscopy, one part of the tail stays on the abscess, the other in the lumen, take down the pressures. It seems to be very effective. So take a look of the systematic reviews that you can see here. There were 81 patients, and you can clearly see they come from France. Most of the papers come from France. Now it's spreading all over the world. And the complication rate is low, 13%, and 84% of success rate. That's very impressive on that. Very few complications. New kid on the block is the EVAC everybody's talking about, is that you put an endosponge with a nasogastric tube inside the cavity or inside the lumen, and you apply vacuum for that. So that's the first publications. They're starting publications specifically with gastrectomy, like these 9 patients, they are all healed with that, but the trade-off is 10 procedures per patient during the hospital stay, over 50 days of hospital stay on that. There's a more recent one that was perfected the technique, and you can see here the way that you can put endoluminally and keep feeding the patient on that. 8 patients, very good clinical success of 87.5%, but the trade-off is 10 days of patients with a nasogastric tube into the hospital, an average of 3 endoscopies to exchange these, and 20 days in the hospital on that. So there's a group in Brazil that developed a different approach. Very simple, we just put the nasogastric tube, 4x4 gauze, plastic over that, and you have intermittent vacuum. So they're very clever on doing that. They present on the DW, they started presentation. So this one thing we developed in Brazil, more for chronic leaks, is the septotomy. So if you have ever seen a sleeve leak, it looks like that they screen. You have a septum, you have a cavity. So the idea is that you go there with APC, or you go with any of the endoscopic knives. So you cut the septum up to the bottom, and then you aggressively dilate with pneumatic dilation that in 1 or 2 or 3 sessions, and you remove the path of the food and the liquids and the food, and then it will remold and end up on healing the leak. So as our group from Brazil published that in different ways. even on on SAGES. And it's interesting how we could let people understand how to do it and replicate that around the world. Another way to do that, but now we have endoscopic suture, just saw our colleagues talking about that. Why not suture in the leak? Not that simple, because you suture the leak, but you don't solve the problem of hyperpressure. So the most useful way to do that is use the stents. And if the stent, the Achilles tendon is the dislodgement, you suture the stent in place. So with success. So this have been done there worldwide with anecdotal experience published on that. And we have these over the scope clips, the Ovesco, that quite some, this very small series have been done. So it's like a bear trap that you apply suction or you apprehend, then you fire that over the orifice on that. So it looks very attractive, but if you see that in better series that you follow that's up again, you're gonna see that from 26 patients, 11 of those patients end up needing surgery on that. So it seems that you have to prove itself more. And we end up with this very sophisticated way to treat chronic leaks, that is cardiac occluders. So those occluders for intra-atrial communication, interventricular cardiac communication. So you put it there for chronic leaks, and you see that. So that's some initial publications and how to do that. Downside is going to have a Fahrenheit body on the there forever. But you can see here, this group published a very good series. And as we can see here, 31 patients of sleeve gastrectomy with 90% of resolution on that, and most of them for chronic cases. And then we have, at the end, these pictures. So we have a lot of different approach to use on the sleeve leaks. As you can see here, these slides come from Barham Dayyeh, Mayo Clinic, very beautiful one. So with the stents, you take down the pressure, you occlude the hole, and then you have the pigtails, you equalize the pressure, and then you aggressive dilate that, so taking down the pressure. And you have the vacuum that that is easier to do on that direction, and also you have the occlusion methods on that picture. So how do we decide? So this, unfortunately, we don't have any good algorithm to describe, because what the literature does is, if I do a method, I defend my method, I do an algorithm over that, and the comparison of the other methods is not absolutely not fair. And we don't have enough robust data to do a meta-analysis of comparison, and not even right numbers to do that. So this is very subjective comparison that I offer to you. This comes from me, so no more sciences, but trying to get some common sense. Acute and earlier, so the options are the stents, pigtails, and evac. Later in chronic, septotomy, occluder, and evac. High-tech and higher press, stents and occluder. Low-tech, lower price, pigtails, septums, and evac. And easier for the patient, so more comfortable for the patient, for sure, the pigtail. Then comes the occluder and the septotomy on that, because septotomy, you do it, the patient can go home on the next day. Hard for the patients, you have to agree with me, that stents with a lot of adverse event on the initial days. And the evac, because you have this nasogastric tube, have to stay in the hospital. For brief hospital stay, pigtails, stents, occluder, septotomy can even be done in ambulatory way. Longer hospital stays, the evac will keep the patient for sure with more time. So the message is that endoluminal treatment for sleeve leaks are complementary, they are not competitive. There's no such the best one, we cannot prove it. There's best one for each situation. They are always complex. We have to look for strictures to take down the pressure, and there's a clear need for an unbiased algorithm. So that's also my topic, that I stay on the allotted time. And I think we can go for the discussion and talk about other complications like bypass complications and blunt complications. So thank you very much.
Thank you.
Thank you. Manuel, this was a wonderful talk. And as you remember, we had almost similar discussion in previous platform a week ago. And we had a discussion, as you said, you know, there is no consensus the final algorithm to treat sleeve leaks. And this is the major nightmare for every surgeon. So, and you put it nicely in summary, in a nice summary. Maybe it was fast when you talked about it, but I think you have given us the options. And those options are according to the size, the site, the timing, and the appearance of the leak when you do endoscopy and look at the leak. I have a question for you, and I know this is, again, very difficult to answer, but I would love to hear your views and the other speakers. When do you give up and tell the surgeons that I can't do anything? Would you continue until
Yes, that's an awesome question. I'll try to answer that. If I may add some variables to what you choose, Mousa, and thank you for your question. They give me the opportunity to answer, is that who you are, what is your experience with endoscopic methods, how much you like them. So what access do you have to the technology? So what is your skill sets with each technique? So here we are facing a very good difficulty, if I may say that, is that on the average, we have around more than 80% success rate. So it's very desirable. And you just highlight the mess that we are, that I say my method is better than yours, and Amit say there, he claims that it's him. So Gontrand say, you know what, I have one better. That's the situation. That is very hard. And the clock is ticking on the lap of Barham Dayyeh, that is our president or coordinator or director of the bariatric endoscopy chapter of IPSO. But answering your question, that's how you can, sorry to create momentum to answer you that. How we quit, when we quit, or when we ever say that we're not gonna do anything. So many variables, my friend. Well, so it is like this. If you are treating a patient and this treating patient is stable, you have your chance, keep on that and keep talking with the index surgeon, keep talking with the family. So if you are progressing, even if it's like slowly, you still have a chance. But you do one, you do the second, and it didn't progress, that is time to quit. Or you're not improving your patient general conditions in terms of the sepsis or of infection control. That's how when we quit on that, because at least in sleeve gastrectomy, any situation we can go win. Even if the patient is unstable and the surgeon say, okay, not do anything more, we can go there. It's a risk that we assume together, but endoscopy allows us to do that.
Wonderful answer. And we had this similar discussion about a week ago. I have another question for you, Manuel. And this is also something we don't have an answer for. How often do you do your imaging, contrast study, and CT scan? Now, the patient can stay with you for 3 months. And do you do it weekly? Do you do it according to the situation, clinical situation of the patient? And we don't have answers. I looked at many papers, and it's a mumbo jumbo. When you see the literature, everyone talks about a different algorithm, a different protocol. So from your experience, you have handled hundreds of leaks after sleeve gastrectomy. I trust your judgment in answering this question, Manuel.
Thank you very much, Mousa. What wonderful questions. Thank you for allowing me to answer things that is on my heart and I cannot put out so often. The first thing, go back to the old contrast X-ray. Sorry, CT scans tell you nothing but what is outside. You need to see what is inside. So the golden standards radiologically to evaluate the leak, the stenosis, the X deviation, it is not CT scan, unless you have 3D reconstruction that is not validated yet, and it's hard to do it. And what I see worldwide is everybody jumps on CT scans and they send me CT scans. And when they ask me to help, the first thing I say, can you give me an X-ray? I say, X-ray? Yeah, because CT scans was meant to see what is outside. So I already know that is a leak. I already know that is an abscess, but I know how it communicate. How if I have some tortuosity that I can anticipate on a two-dimensional way of this X-ray. And also endoscopy is very important. So I trust more in doing my simple X-ray, like in the stent. You put a stent, and yes, you have a contrast X-ray, you put contrast inside, you use endoscopy, and you put your stent. So each week, if you have a patient of stents, each week, because we know the Achilles stent, we already know that is around 30% migration. So you're the obligation to follow those patients. So each week, you need at least an X-ray, simple X-ray. So you put, and you see the column, you see the vertebra. So you put them together, align, taken the same way, and you can see if it's dislodged or not, and also follow the symptoms of the patient. The most basic principle is that you know that stents, they hurt the patient. So if the patient say, you have a stent, and the patient say to you, oh, I don't feel nothing, go back, go there, your stent is not there anymore. And keep it for 4 weeks. With pigtails, you need contrast X-ray for the beginning, and you go directly and do that. And very few X-ray or CT scans. You just leave there and follow the patient's symptoms. With the vacuum, you might not need imaging on that. With the occluder, you need some imaging to put it there. Septotomy, we basically go on the visual way. So I hope I could answer you, because it's so variable. And the only thing I can do is, as you ask and you state, is transfer.
Okay,
Yeah,
Shashank, go ahead.
Can see him now.
Shashank, chalu kar. Chalu kar.
Welcome to Mohit. Today we have a 56-year-old female with a weight of 87 kg and BMI of 35.29. She has no addictions and has osteoarthritis, obstructive sleep apnea, and hypothyroidism with the comorbidities. She has a good blood profile with an albumin level of 3.9 and HbA1c of 5.42. She has been tested negative for all the viral markers, including COVID-19, and the USG showed grade 1 fatty hepatomegaly. Over to Dr. Mohit.
Okay, so good evening, everybody. We are ready with this particular case. I just put the overtube in the interest of time, because we have all leading experts on the panel. Plus, most of the surgeons and gastroenterologists interested have already seen this step couple of times. So this patient is a little huge as compared to most of the other cases which we do. I initially offered her a sleeve gastrectomy, but she was interested in a non-surgical treatment. So this is the incisura. Now, one of the common mistakes which most of the surgeons or the interventionists can do is consider this as incisura, but that's not the incisura. That's the pylorus. That's one of the folds before the pylorus, and then when we pull the scope, this area here is the incisura. I work with a little less air as compared to most other gastroenterologists, so I would start my procedure here. We would first load the needle. So I have already loaded my needle, and so the basic principle here, what I have been taught by Manoel, and after discussing with all other leading experts, is to start somewhere between the line which starts between the greater curvature and the anterior wall. So that's somewhere the area we usually start. And obviously, when we have a lot of this air inside, it might sometimes become difficult to pull this tissue. So I would not pull this tissue at this stage, but remove some amount of air. So you know what should be the amount of air which one should keep inside. I think I should see my folds partially. So this is what is I wanted to demonstrate. You have to see these folds partially, because I was doing it under too much of distension, the possibility of getting a good bite always reduces. So now you can see I got a good bite, and this sometimes become much more easier if we sort of use this. Now you see that I'm very close to the tissue, so I'm pulling my scope a little bit back, which gives me more space to work around, and I can load my needle again. Now I can go a little inside. So this, we can see that the line of force will follow itself. So we, it's not a rocket science here. We keep on following these lines of forces and they come to us. So I usually do not use any marking device like argon or something to mark this area. What I principally feel is that, and we have seen in bariatric surgery, when we do sleeve gastrectomies, like today I did 6 of them, I could feel that the anatomy was very different in all of them. I mean, all 6 sleeves were different. Some sleeves had more amount of, you know, uh, area in the body. Some of them have had more in the area of the fundus. So they're all different. As you can see, we have reached an area where I have taken the vertical of the U. Now, this particular zone here is a no-go zone. So I'm not going to go here, because if I go here, I will obstruct this lumen completely. So this is the area where we usually stop and do not take the sutures. I would try and take the posterior layer. So you can see that and when I take the posterior layer, I go a little bit on the sides uh, on my right hand side, which gives me a very good egress to the tissue. So we have to keep our body very, like when we do a run, we need to keep our body very flexible. We cannot keep it tight. Otherwise, we cannot breathe properly. If the shoulders are tight, we can't breathe properly. Similarly, in endoscopic sleeve, the body has to be completely relaxed so that you can twist around, make movements, and take good bites. So the principle is that keep the body very relaxed. You may need to go on different directions, and the way I have been taught, I keep it very flexible and I try to take as much of tissue as possible, which is, you have a limitation to the depth of the tissue you can take. Some of the tips I would share with surgeons who are new to this procedure: I always load the needle towards my assistant, so which makes it easier for me to see what is happening. And whenever I don't see anything, or whenever I have a problem or difficulty in seeing things, I pull back the scope. So these are the 2 tips which we learned uh, while doing this procedure, that whenever you are not able to see it, always make the always tubularize your area by pulling the scope back. So I think I have started from a place and I have come. Either I'll drop my needle here and I'll pull this back. Now, as you can see, this is a nice bit of a U which I did. And what I can do now is hold this and make it a little bit tighter. But before I do that, I usually would remove most of this air. So we are removing the air and we will cinch this. Now, when I remove the air, I do not, pull it very, very tightly, although I know it can bear the amount of pressure, even the weight of the scope, which we demonstrated in most of the workshops, but we don't, pull it very, very tightly. Now, at this stage, as you can see, my assistant is maintaining the pressure or the tension over the suture, and I am continuously putting the cinch inside. Once the cinch is in my vision, you can see this resembles what we used to do in our days of appendicectomy. We used to pull the Roder's knot, and there was this where we used to push. So I'm pushing by my cinch and pulling the thread. Can you cinch it? So my assistant has cinched it, and you can see that I have a nice thing. The good thing is I can see the lumen. So lumen is still nicely visualized to me. I have no problems here in seeing the lumen. I can pull the scope a little back. So now you see a beautiful tube which is coming in. And this is exactly what we need. We don't need more air than this. So I get this question quite frequently. What should be the amount of air inside the stomach? So I would say you should be able to see the folds, little bit of fold should be visualized. If we stop seeing the folds, which means there is too much of air, and the possibility of taking a surrounding tissue will always increase. So that's my trick to most of the surgeons who started. I always say, keep little bit of folds so that you are able to see. So this is the exact amount of air. Now this was the area where I cinched. So I'm going to go a little up above here. I'm going to pull this tissue. So you can see that there is a synchrony between me and my assistant. I don't have to instruct him for doing things. That's the advantage of working with somebody you work daily with. So you can just, work in the flow and do things and do it quite fast. So we have 5 parallel theaters working now. I operate in one of the theaters and go to the other theater to operate. So we do our bariatric surgeries and bariatric endoscopy all in tandem. So, that's the reason why we have to work with team. And it's always easier to work specifically in bariatric endoscopy if you have somebody who would know the task perfectly. So you don't need to, continuously ask. Now, this is a small amount of valley, and we are taught by Manoel to take these valleys. You cannot afford to leave them. I don't practice the reinforcement technique, which I think Abu Dhabi and Manoel developed, and they're working on the merit trial. We are happy with our results that way. Once they publish the trial, and as Manoel has instructed us that the trial results are pretty good, we're gonna practice the reinforcement technique. I'm pretty happy with my results now. We are getting good weight loss by compliant patients. I believe even if you reinforce these sutures, if the patient is not compliant, this procedure will not work. So I'm always, somebody who would feel that procedure does not work because of maybe compliance or other issues. It usually fails to work when we have problems where the patients are not following the lifestyle, or maybe most of these patients would believe that this is as strong as bariatric surgery, and they stop to take their medications, stop to follow a particular lifestyle. So I feel it's more of a problem of compliance than a particular technique, because these procedures, patients will have to understand that it's not that the amount of stomach tissue restriction is not as high as sleeve. At the same time, it is pretty good if somebody is compliant and is ready to understand the limitation of the procedure. It's very good, and we have more weight loss even than the bariatric surgery for compliant patients. So we are at this point of time happy. You can see that I took the vertical of the U, and now I am going to make a little bit of base here. Now, for example, if you have this bleeding, there's no problem. You can keep on suturing, and most times this bleeding stop in the process of suture. So what do we do in general surgery or in laparoscopic surgery when we have bleeding? We start to take sutures and continue our work. We don't stop. Now you see I had bleeding, but it stopped completely as soon as I took the stitch there. So the bleeding is not a problem here. You don't have to stop. So another instruction at this point, if I'm not seeing clearly, I'm going to go close into the valley and then twist my scope and going to go close. And you can see now I've gone close. I took a bite and then I'm back here. So the point is that just like in laparoscopic surgery, if you don't see, you try to see as much as possible and then only take the bite. Similarly here, we try to see as much as possible. We go close into the valley, try and see the tissue by rotating the scope, by pulling the scope back and forth. And then once we are very clear that, okay, we are taking the bite at the correct place, only then we go ahead with the procedure. Every time when I load my suture, I use the larger wheel to go a little bit up towards the 12 o'clock position. And then I use, I always load it towards my assistant. So you can see that I'm not having any issues whatsoever in loading of the needle. At this point, we have reached to the
Mohit,
last.
let me interrupt you for a minute, Mohit. Alqahtani, how do you, are the bites large enough? Are they adequate? Aayed?
Yes, yes.
What do you think about the bites Mohit is taking?
I think it's great work he's doing, Mohit. I will not honestly do much different in terms of the techniques. Always, it's when you are intra-op, you will feel the tissue, whether you are full thickness or not, by having the twist of the helix and pulling the tissue. When I am getting the mucosa only, I'll feel the tissue is very thin in my hand. And even when I pass the needle through, I'll feel I am only in a mucosa. There is no wall thickness. You will feel it. So it's the operator will feel he's through the wall and through as full thickness. And I think he's doing full thickness here. The other things also on the right side, I think also he's trying to create a very nice symmetrical sleeve, endo sleeve, which is very good because that will minimize the patient post-op complication. He's not tightening here too much to have the suture under pressure. that also will minimize, will at least maybe increase the durabilities. You can see here, you have very good sleep and symmetrical. You don't have a lot of twist around it, which is very good.
What about the distances he's putting between the sutures? Are they adequate or too close?
I think they are good. I think the distance is okay. They are fair, average, not very close and not very far. Usually we aim about 3 to 4 per row. So this is what's happening now.
Okay.
If I may do a comment that is 200% bias, am I allowed to do that, Mal?
Sure, that's the whole idea.
I'm just loving that. So I'm so happy to see this exactly the same way what I will be doing. So this is 200% bias comment. Please go ahead.
Thank you, thank you. Well, that's why I want to get the feedback. Barham, what do you think?
I think Mohit is doing a great job. This is the U pattern suturing that we're all adopting right now because it's efficient suturing. The only thing I would do different is I am a fan of reinforcing, and each use sequence like this gets another triangular reinforced line with it. That's the only thing I would do different, and that's what the Merit trial, which is the multi-center randomized trial in the US, is following. We will see. We will be very objective in the trial, actually, because we're doing MRIs to look at the outside of all of these sleeves at 1 year. So we will be able to tell what's the percent intact and how the durability and all these cool things. So we'll see. The jury's out still, so I cannot tell for sure that reinforcement is better than no reinforcement or vice versa. But I think what Mohit is doing is a very standard U-shaped, nice, symmetrical sleeve that I think he's doing a great job with.
Manoel, is there anything your people can do to improve what he's doing?
Yes. What can be done, it is not due to the procedure. The procedure is a nice standard way. What can be done is on outside with the multidisciplinary team. So Gontrand Lopez-Nava, and I asked him to jump on that, has show us the way how to do a concierge follow-up for the patient, perfecting the results. So now, what we are doing now, what you see on the screen is best technique available, best standard. Outside on how to select, prepare the patient, and how to follow the patient, that's the key to put it over what it can give to us. So Gontrand, if you can jump on that because you're the expert. I will keep Barham because he have also an awesome way to follow the patient. So I leave in between you two guys that you guys are GI, by the way. So go ahead and explain to us.
If I may comment now, what is you can see on the screen.
Yeah, so this is a nice thing. Now I have my needle which has got the suture exchange catheter which has got a little problem. It's not coming on the way of my holder.
Mohit, turn the needle exchange with your fingers, turn it 180 degrees, and you will achieve it.
That's what I'm doing.
Yeah, because it's a little bit bent. Not the arm of the device. The needle in the needle holder is a little bit bent.
That's what I'm doing.
Yes.
Another thing perfect. Another thing you can do is move your body completely to the right of the screen.
Yeah.
That you do the same.
Yes,
you got it, Mohit. Beautiful.
That's what I was doing.
So Mohit,
yeah.
You are doing a fantastic job, but let me for the audience play a little bit the bad guy so we can discuss and do things. So I love the way you are thinking. This is key, and this is very important, the tension of thinking. So with this, I'm very nice to say that it's a fantastic job. Also, you are taking perpendicular bites, so you are achieving full thickness bites in most of the cases for sure. Maybe the thing I would love you to try to do a little bit more is to focus also a little bit more in posterior wall, because I think if you put the greater curve at 6 o'clock, you will see that posterior wall which remains at 3 o'clock in the orientation clock. You will see that the sleeve is going a little bit versus anterior, which is the left, and you're maybe missing a little bit on the posterior. Sorry to say this because maybe it's my perception.
I would exactly cover the posterior wall once we are done. We are just struggling technically with this loading and unloading.
Okay.
I'm absolutely going to do as you say. I'm going to work on more on the posterior side of it. So this is the posterior part.
Mohit, yeah. Let me save you from Gontrand for a while.
I knew he was going. I knew he was going to rescue from my comments. So I cannot play the bad guy.
No, sorry, Mohit. You can't be safe on that unless I jump on it. Gontrand is just saying to you a thing that the needle is dropped. Oh no, the needle is there. The only one in the world that can do that is him.
No,
because I'll tell you a good history. He was not from this original parents raised by. He was followed in an arena of a bullfight. So all of the movements that he do come from the bullfighting maneuvers, the torero maneuvers. So he's the only one that can do that.
No, it's not true. Mohit, I'm impressed because as you see, we don't see other colleagues many times to do the same procedure, and I can see that it's a very, very good suturing pattern and results. You know, you're struggling now with the.
No, I'm trying to basically what I'm trying to do is
to catch.
We know this will happen, and it happens with all of us. Like sometimes we close fast on the needle, and it gets a little bit, the axis is deviated. Yeah. As you can see, it's bent needle.
You see the needle, the needle is bent.
The needle is bent, and I'm keen to drop it so that I can start it back again. So I'm trying to load it back.
But the only thing you can do now, my friend, is get a grasper, take this needle out, and drop it. And I don't think you will be able to take that with the needle holder because it's bended. It is completely bended.
And one advice, if I can give you one advice, once you see the needle bended, but you have it you still have it in the needle holder, it's much better to release the needle, because otherwise, when you have it in the arm of the system, it's going to be harder to
what I'm gonna do instead is I'm gonna cut this needle with the scissors and pull it out. So
or what Manoel suggests is very good. You can take a grasper and try to take it manually.
Yeah, that also I've called for both.
Remove it from the needle holder.
And I agree with you, Gontrand. Like when we have this problem, it's your two options. Either you try, as Mohit have done, to save the needle and to save the thread, or you just save your time and just.
I would have used a grasper here if I would have been able to save the needle, but I think I'll have to do this.
Absolutely.
Yeah.
Let's see if I can.
Okay, I just want to ask one question to everyone, including Mohit. Mohit, you're doing a fantastic job. Just one question to all the experts here. What is the technical thing you can do to prevent this needle from bending? During the procedure, what steps you should be careful about so that the needle does not get bent?
Wow. I'd like to make a comment here, if I may.
I think the safest approach not to bend the needle is to keep it in the channel and then close the device and push the needle driver to the device. So that's, sometimes we're quick about it and that's where it bends, but the safest approach is to keep the needle in the device, close the suturing arm, then advance with alignment until it clicks. That's probably the safest approach in my opinion.
And also I will add, always any resistance, don't push against resistance, and always do everything under vision. When you load and load, make sure you're sitting and loading. It's very easy to see the things, the cap going through, the click in your hand. It's very easy. Any force beyond that will create a problem.
So to
Yes.
answer Amit, what you said is there are two main reasons when the needle gets bent.
Bent, yes.
One is when you do too much strength to give the needle to the arm of the system, so you push too much.
Correct.
And the second is maybe you're working, your needle holder goes out, and you close the device against the needle holder, so you can bend the needle if it's in the arm. So it's two things that are happens often in expert hands, because you go quicker, you go down. So this is related to expert hands.
I think what the first point which you said is the most relevant, because when you give too much pressure, when you're trying to load and unload the needle with your needle holder, that is the time, if you feel that the needle is not engaging, might as well release it, select another spot, and then again try to catch a tissue. That will prevent bending of the needle. Am I right?
Yes.
The experts?
Yeah, that's exactly the reason.
We have a trick also. What we do, we go with the whole scope inside. So the suture is not under tension. And then once we go inside, we rotate the grasper of the needle, just rotate it a little bit, and then we close. And usually we get it immediately.
Yeah, I think he tried to rotate, but he couldn't achieve it. But another thing you can do, Mohit, is
Gontrand, it's true, but the problem is that it was under tension, I think.
Okay.
I think he's going to catch the needle and pull it out, I think. Yes,
catch the needle with the grasper, perfect. That's
okay.
Yes, and pull it. You got it.
Very
exactly. Good. And now release the needle in the lumen. Yeah, exactly.
That's what.
Awesome.
And
so that's what these live cases are very nice.
So now the reason why we did this was so that we can cinch it here and we are not wasting the amount of bites which we took. So we'll cinch it here and then again start over. So one of the reasons why I feel I always have a needle which goes this way is I try to take bites more thicker. So I have problems exchanging it, and I think Apollo endosurgery with this kind of device, you can only, I don't know about pose, Gontrand would be able to throw more light, but I think you can take more thicker bites with pose. Am I correct, Gontrand? I think this is, whenever I try to take bites.
Well, honestly, the big difference between these two procedures, pose and ESG from Apollo, is the lasting of the sutures. Maybe I think the sutures are more effective than the plications, but definitely the plications last longer than the suture, because we have many pictures of more than 2 years, 3 years, 5 years, and plications are there. Maybe not so effective, but they are still in place.
Okay, so now we are starting with the, maybe you can say this was one of the layers, which was a third layer, but now we're starting with the actual formal third layer. We have a nice tube as of now. Now we're gonna go here, and as you said, Gontrand, I have to take the posterior wall. I'm gonna go a little bit posterior, but not at the cost of the lesser curvature. So we know as sleeve surgeons that when we try to take more posterior walls, like for example, I know you must have seen a lot of sleeve gastrectomy surgeons, they try to pull the tissue of the greater curvature more in the stapler line. And whenever we do that, I have always seen that my staple line turns downside. And that happens as a general surgeon or as a bariatric surgeon, which I see quite frequently with the staple line turning down. So if I try to pull more tissue posterior to the stomach wall, I have this issue which I usually face. So you think we should continue? Okay, we'll change this device also. We'll change the needle holder as well, so that we don't have a problem.
Yeah, because
I don't want to.
The arm of the system is bent.
Yeah.
It's got a little bent. Yeah.
I have a question for Barham, if I may ask.
Go ahead.
Barham, when you do the reinforcement, have you noticed an increase in the post-operative pain? Because in our experience, we have seen that if we put more sutures, we get more pain post-operatively. So I wonder if you had a similar experience among your patients in the Merit trial.
Yeah, Mousa, I'm not sure. I haven't sensed any difference between the reinforcement and the regular, but we've been adopting this enhanced recovery pathway where we throw the kitchen sinks as far as Decadron, Zofran, IV Tylenol, a little bit of narcotics, antispasmodic. So recovery has been smooth, and I would tell you with the Merit trial, there's no overnight admission. They all get discharged on the same day. So, and we will show that that model works, and I could not sense any significant difference as far as recovery, pain, or nausea if you reinforce or not. The idea is do not
focus on the faculty while we discuss.
If you remember, Manuel, when we were writing our paper, you know, we have come across one of the authors who had a similar experience. When they reinforce the suture line, they get much more pain among their patients. And we have noticed the same thing. So if we put, let's say, 5 sutures, and it's very strange. Whenever we reinforce, they get more pain. I don't know why. We give them the same protocol you give, but we still see this. I mean, problem.
Well, data Mousa is coming soon. The Merit trial, as you know, is concluded, and now it's in the second year of follow-up. So that should shed some lights, but we tried for uniformity to have all the suturing techniques be as such that you do the sequence and you try to reinforce at least the most distal row of it. And my sense is we did not see much difference recovery as far as pain and nausea, but I'm not surprised with your experience, because the more sutures you put, technically you're bridging the serosa multiple more times, and there's higher risk of serosal inflammation and what have you. So I don't know the answer, but my experience has not been as such.
Thank you.
Okay, so we have loaded back.
Welcome.
Sorry.
Welcome back. Welcome back. Welcome back.
So I just changed it because Abhishek was not happy changing it, but you know, we just changed it because I think it would not work. I don't want to waste time. So here, as you can see, this would be, I think, 3.5 maybe the layer which we took. So I'm not very happy with the previous layer there. So maybe I'm gonna sort of reinforce that layer back again. So I'm gonna go a little close because I don't think that the third layer was up to anybody's satisfaction. So we're just gonna go closer here, a little closer than what we would have gone usually. But what I consider here is that since we are getting good bites, the tissue thickness is coming pretty well, even going closer, because we just took 2.5, and that's not a third formal. When we do reinforcement, we have done a couple of cases here reinforcing them with Manoel. It's a little tough to take those bites, and Abu Deb would agree. It's not as easy. These bites come so easily, and when we take bites there, it's a little tough to go on the tissue where the bites are taken and then go and take the bites. You have more problems. Now about the posterior wall. So this is a no-go area for me. I'm not going to go here. But what I'm gonna do is I'm just gonna clean my scope and go a little posteriorly as Gontrand wanted me to go. So I'm gonna go here, a little posterior, because he feels I'm more anteriorly than posterior. So I'm gonna go just take this tissue, but not more than this, because I personally feel, and we have seen that even in sleeve patients also, that whenever we have such problems, even in sleeve patients, we
You are very talented, Mohit. You are so good.
Hello?
Yeah.
I think we lost his voice.
Yeah, Manuel, I remember when you taught us, myself and Mohit, the ESG, on the posterior wall, you showed us that you have to turn your body completely to the right, face towards the posterior wall and take that area. But now we don't see Mohit doing it. What do you think? We should do it or we should not do it?
it is that the maneuver that you go completely to the right side allows you to get a bite directly to the posterior wall in a straight perpendicular way. If you don't do that, you go like sideways on obliquous that way. I don't know what to say. I think that if you go directly, it is more like following the path of the suture. But as you can clearly see here, it works.
It works.
And with that, you don't move that much. What I see, if I can comment on that, is that GI oriented guys like you, like Barham, like Gontrand, like myself, we do this maneuver more easily. And surgeon-oriented guys, they prefer to stay on the center.
Yeah, maybe one thing, I don't know, Manuel, what you think about this, but in Madrid, the way I do it, I put the monitor and my assistant on my right. So I'm looking more facing the head of the patient. So let's say that you are 90 degrees already to the right. So whenever you want to face the right side, you just have to move another 90 degrees to the right. So the neutral position is slightly different from the one of Mohit.
Yeah, I know what your preference. I prefer to have at least 11 monitors in front of me, not to say 12.
Yeah, this is in Mohit OR, I'm sure you have it, but in Madrid, crisis, political crisis in Spain.
A question that comes up is, at this time, it looks like this procedure costs as much as a sleeve gastrectomy. Do we see a time when this cost might be reduced?
That's $1 million question, Professor Fobi.
One manufacturing company. We have to change that.
Yeah.
That's good. They have a monopoly.
Amit,
yeah. We have to welcome competitors.
Answer that question because it's an important one as well. Is the concept here is to create an endoscopic sleeve gastroplasty. That means a shortened stomach with a tubular greater curvature and a small pouch in the fundus. How do you get there is not really important. You could get there with suturing. You could get there with plication, like with pose. You could get there with the Endomina device. The shape is what's important. And once we get that, I think the competition is going to drive the prices for these procedures significantly down. And I think we'll see that it should be a procedure that is well afforded by patients in order to be widely adopted. So I think the price will come as these technologies mature, and now there is competition in the market with these devices.
But as far as the devices are concerned, I want to ask all of you, other than India, how do you compare the prices of these three devices: the pose, the overstitch, as well as the endolumina?
So which one is in the US? I could tell you that even at the current prices, the cost of this procedure is about half of sleeve gastrectomy.
Oh,
so in the US, with the current price structure, still there's differential.
Yeah, at least in Mayo Clinic, in Mayo Clinic, yes, and it's because you don't pay taxes, extra taxes, or double, triple taxes as we pay when the devices go abroad. Here in Brazil, it is almost 50% more than a sleeve gastrectomy. I don't know about you guys.
Oh. 50% more than a sleeve gastrectomy. And what about the in between the three devices? Which one is the most expensive to construct a proper endoscopic sleeve out of these three devices? Gontrand, you are doing everything. Maybe you can tell.
So you mean which device compared with Pose, Apollo, and Endoscopic, for example?
Endolumina. Yeah, out of these three, which one is Endomina? Which one is the most expensive to construct a proper endoscopic sleeve?
Well, I am afraid that only in the market, so you cannot pay if you are not under study for Endoscopic yet or Endomina, at least to Spain. But in Spain, we pay for Pose material and ESG. I think both companies, they have agreed, or maybe they have shared meetings, because the price of 18 plications with everything, nothing is reusable, of course, with post-procedure, 18 plications could be similar price of ESG procedure with 5 to 7 sutures. So yeah, it's very, very similar, very similar.
Okay. Okay.
The thing is, for example, if you want to redo a case with Apollo, it's much cheaper than to redo a case with Pose, which is you have to have everything brand new.
But Professor Fobi, I think head-to-head comparison in India, probably endoscopic sleeve is still cheaper than a laparoscopic LSG, right?
Definitely, yes, it is.
Yes, it is.
Because your cost of healthcare cost and hospitalization cost in India is much less.
Yeah.
In India, the cost of the equipment and the sutures almost accounts for 60 to 70% of the cost.
Yeah, that's right.
Whereas in the United States, it's about more like a quarter.
Yeah, that's right.
Yes.
So the surgeon, so the endoscopist is earning much lesser when we do an endoscopic sleeve.
Well, the hospital and the endoscopists and the anesthesiologists in the United States get quite a bit of the money.
Yeah.
Correct.
Yeah.
In India, it's the other way around.
Well, it costs less for the food in India, that's why. Okay, Himanshu, let me know once Mohit gets everything in control, and then we will join him. While we're waiting for that to be controlled, any questions or any other comments from any of the experts?
Yeah, we have already
I think
taken
I think it's a yeah. Go ahead, Mohit. I'll finish.
Go ahead, Mohit.
We have already taken the third layer. I'm just trying to clear the fundus with this clot so that I can take the fundal sutures. The fourth layer so that I can make it a tight sleeve. I already have a tube there. So this is the Z line here.
Good.
As you can see, and I'm going to enter here. So I have already made that part, but I'm going to go here and just suck this blood clot so that I can take nice sutures there.
What I wanted to comment to you all is that we should be very happy. We should be very proud, because our generation bring to the light of the clinical use a new procedure. The endo-bariatric that we have before was the balloon 20 years ago. And we all that here, we should be complimented the way we are doing, with good science, with publications, in a stepwise manner. And we know that the resistance against novelties, unfortunately, it comes in waves. We are in a wave that it's hard to come with a novelty in our fields. So we have resistance from the regulation agencies. We have resistance of our peers. What we don't have resistance is for our patients. And believe me, that's why we are still here, because the patients want it there. It is not the academia. It is not our peers. It is not the regulators. And it's exactly the same what we saw. And I embrace the words of Fobi, that he is a man, a very smart man with a very good heart. What you might not see, maybe he's seeing, maybe I'm seeing, because we have passed to that. We have passed from open surgery to laparoscopic surgery and endoscopic surgery. So again, I compliment to you all and welcome you all to this new world that we as generation, we were able, we all together, we collectively, we bring to the light of the clinical use a new procedure.
That's well said. I would like you to know that you are not encountering more resistance than we did when we started doing bariatric surgery. We encountered more resistance than you are getting for doing the endoscopic procedures. As a matter of fact, in the 70s, we were considered quacks. And we were told we were operating and stapling the stomach of people with psychological problems, and that we should be stapling their brains. So yes, you're doing a great job. And as I said, I would not be surprised, by 2025, most bariatric surgery would be done endoscopically. And the rate is progressing, and you guys are doing a fantastic job. Mohit, are you ready for us to look at the last part of it?
I'm already doing the procedure. I hope you are getting the pictures. No?
No, we're getting to you now. Go ahead.
Oh,
Yeah.
I'm doing it since a long time. I thought you're not. I'm already getting the
No,
pictures.
that's fine. We wanted to.
So
we're getting the pictures now.
So at this position, I'm just taking the last bit because I'm actually working at the Z line. So I'm here, and you can see my position.
Yeah, I can see that.
So I'm trying to twist this scope and trying to bring this tissue close to me so that I can take a nice bite here without compromising the needle.
That's a good bite.
Can I make a comment, Dr. Fobi?
Please go ahead.
I think just to support what you have said, and Manuel, it's very important that we have to do this as surgeons, because otherwise we are going to lose bariatric surgery in the future. And I think, you know, as we did in the past, that the gastroenterologist took the endoscope from us. Fortunately, we were able to keep the laparoscopy. However, if we don't start to do endoscopic procedures, the gastroenterologists are going to take this from us in the future. So I think all surgeons should be trained in endoscopy and do intervention in the endoscopy and do endoscopic bariatric procedures.
You're absolutely right. I'll let you know that in the latter part of the 60s, when I started my residency, the medical doctors used to call us to come and place central lines for them. Before long, they took over placing the central lines and doing arterial operations, and the big hospitals that we had for cardiovascular surgeries disappeared. So I can see that happening with this. So Mohit, let's see the last suture, and then we'll make some comments. We have gone about 20 minutes beyond our scheduled time, but that is understandable. Himanshu, give us just one more peek.
Yeah, are you seeing the pictures and images there?
Yes, very well.
Just coming in.
I thought you are not seeing. So I'm just done with. I'm just doing the last bit of suturing. There is no area for me left, so I'm just trying to get some space so that I can go back as a reverse. So you can see that I have already taken this photo. So this is the Z line, and I'm going to go up now. It's a little tedious here because there is limited space. So I'm actually bending down, and as we know, the trick here is, as you can see me, I'm almost completely bent down, and then I go here exactly at the 9 o'clock position. Now here the issue is, I know that there's a lot of clot there, so we have to be dependent on our imagination. So I can actually feel it that I have taken the correct bite, and because I've been doing it since that time, so I know that I have taken the bite because there is some clot there which we tried to clear it off, but it's so thick that it did not come out. So I just tried to continue the case. So now we are here. We are again going into that area of fundus, which is a dependent portion close to the short gastrix. And as you can see, I'm pulling the tissue towards me. I can feel it in my hands that I, got the tissue and I could exchange the needle. So now for the one last final, this thing, I would just pull this here a little bit, again, load my needle, and then I'm going to go a little above there as a final here. That's area of the short gastrix. You can see the cardiac pulsations there. I'm going to go up, get a bite from that area. So that's it. I think I have exchanged it. I think I can take another one, a little bit more at the top. Now, one of the difficulties here is to load the needle and get the space. So the best way is to pull the scope back, and then I can load my needle again. So I can go somewhere here Okay, so that should be the final.
That's a good bite. Yeah.
Excellent. Very nice demonstration, Mohit. Fantastic.
So now I can go and I can drop the needle. And sometimes when I face the difficulty to drop the needle, I just keep on pressing the blue button and then a little bit of pull. And now I can cinch it and then we can have a final look at the tube.
Good. Perfect.
Okay, so now I can lock my needle holder, put a little bit of more air so that I can go inside. So that's the tube which we created.
Very narrow tube.
That's the pylorus, and then I can pull this back.
That's your fundus.
And that's the Z line there. This is a very small fundal area which is left. And that's the Z line.
Mohit?
Yeah.
Nice demo.
Mohit, do you mind to show us with a scope without the instrument?
You want a single lumen scope? Or you want to
double lumen, but without
okay, without
the device.
Okay, I'll remove the device. Yeah, just a minute. I'll just remove.
But I think this was a classic example, yeah, where you how to overcome the difficulties. For example, bent needle, brisk bleeding during the procedure, and what Mohit did to overcome it. So I think these are the problems which everybody will face when they start doing the ESG procedures.
Exactly, and that's a good demonstration of not everybody is fitted to live procedures.
Yeah.
Mohit is. We are. So that's how we endure it. It is a beautiful demonstration, and then what matters at the end, we're gonna see the end results, the beautiful one.
So that's my Z line here, as you can see, and that's a fundus and
Nice.
the tube which we created.
Nice.
And that's there is the pylorus. I pull this.
Very good.
Nice job, Mohit.
Great.
Very
Excellent.
nice.
Congratulations.
Beautiful demonstration.
Congrats.
There are a few questions from the audience, but we have exceeded our time. So I will respond to them by email since we have the contact of all participants. I want to thank the faculty. We are lucky and we are honored that we got this group of faculty members, all of you esteemed leaders in the field. We appreciate the fact that you've given your time to VBU. And we thank you very much. We're going to reach out to you again in the future for other courses. I want to thank Mohit and the team at Mohawk for being patient and handling a very difficult situation very well. Again, thank you. At this time, we would promote the next VBU session for next week, and Himanshu is going to go into that. Mohit, do you have any words to say apart from say thank you?
Thank you very much, and sorry for exceeding this time. Sometimes we have technical difficulties. Thank you, everybody. Thank you, Gontrand. Thank you, Manoel, Dr. Khoursheed, and Abu, and Dr. Fobi, and Dr. Amit Maydeo. Thank you very much for being on this show. Thank you.
Thank you, Mohit. Excellent.